please take your seats? Thank you very much indeed. My name is Fiona Godley. I'm Editor-in-Chief of the BMJ, and it's my enormous pleasure to chair this next keynote session. I think we are all part of something rather fabulous here. Those of you who've come all the way to beautiful Copenhagen to discuss, consider, explore the very complex and fascinating issue of overdiagnosis. Those of you who, like me, have been on this trail for some time will remember the days when it felt incredibly radical. And I think perhaps it is still a very radical concept. But what's rather encouraging is the sense that it is becoming increasingly mainstream. And the very fact that we have WHO as a sponsor of this, or a collaborator in this conference, is an enormous statement of that sense that this is really gaining traction as an idea that we can put medicine back in its rightful place in our lives and wind back the harms of medical excess. So I'm feeling encouraged, and I hope you are too. Just two quick notices. The first to say is I've been asked to mention the fact that for the BMJ, if you have something you want to say that isn't research, but is a well thought out opinion or an analysis of some issue that you feel needs exploring, please do consider our analysis section and also our opinion section. One is much more academic and reference, the other is more of a kind of personal view, blog type of thing. And we really do welcome, especially from an audience like this, those kind of well-informed, courageous, status quo changing commentaries. We would really welcome those. So please, if you want to consider writing such a thing, do email me, fgodley@bmj.com, and my colleague Helen McDonald is also in the conference. So we'd love to hear from you. The second thing is, after this session at 1 o'clock, there is a session on how I got involved in overdiagnosis. So I hope you will join us for that, where people will be talking about how they got the bug of overdiagnosis. So the aim of this conference, as you know, is to continue to understand and scope out the problem of overdiagnosis, but also to look for solutions that are practical, evidence-based, and which put the power back in the hands of patients and the public. And this session is about power, and it's particularly about how the regulators and health authorities are drivers of overdiagnosis. And we've got three fantastic speakers from different perspectives: Soren Brostrom, Salvatore Varicella, and Paul Bassi. And they are very well placed to help us with knowledge share and debate on this issue. So what we're going to do is we're going to hear from each of them. We could hear from them for much longer, but we've agreed they will each speak for 20 minutes. And then we will have a panel discussion, before which I will be asking for some comments from the audience. So if while you're listening to them you could write down your comments, questions, I'll be asking for a quick blast of 4 or 5 questions, comments, briefly from you, and then we'll revert to the panel and hear their responses. So that's what we're going to do. We are going to do our best with the microphones. If you can't hear, give us a wave and we'll try and do better. But first of all, I'm delighted to introduce Soren Brostrom, who is the Director General of the Danish Health Authority and also an obstetrician and gynecologist. And he's going to give us the Danish perspective on overdiagnosis. Soren.
Thank you very much, Fiona, and thank you very much for inviting me to this conference, and congratulations on the large attendance and interesting program. Unfortunately, I couldn't attend yesterday. It looks very interesting. As Fiona said, I am by training an obstetrician and gynecologist, and I worked for almost 20 years as a clinician and academic in that field. And then 7 years ago, I became a civil servant. I enjoyed being an obstetrician and gynecologist very much, and I also enjoy very much being a civil servant, so it's really competing interests. It's also exhausting, so I'm sure in another 10 years I'm going to retire from civil service, and then I'll go back to being an obstetrician and gynecologist for another 20 years, and then I will be 75, and then I'll be allowed to retire. So that's how it works in Denmark. Just by way of declaring a potential conflict of interest, I am employed by the Danish government. I receive a fairly generous salary for my position. I also have a little bit part-time job for the University of Copenhagen. I advise the government on policy and I execute policy but I'm not a mouthpiece for the Danish government. But of course, in my position, there will be a very few limits on what I can say and not say. So just by way of conflict of interests, I am also here presenting wholly the view of the Danish Health Authority and myself. So here we go. I've been asked to reflect on how health authorities can diminish and prevent overdiagnosis. And first, a little bit about the drivers of overdiagnosis in Denmark, because we certainly have also in this country drivers of overdiagnosis. I just picked randomly, and it was very easy to find, some news clippings from recent years in Denmark. This is a pediatrician, very well known, and he's saying here that very aggressive statement. This pediatrician is saying that the Danish Health Authority and the Danish Medical Authority, it's a scandal that they are not recognizing obesity as a disease that needs to be treated in hospitals. Here is an article about the benefits and also the price in private clinics for being scanned on your carotid arteries. And in this article, which is 4 or 5 years old, there was also a professor and a researcher at one of the university hospitals saying the Danish Health Authority needs to look at this and this needs to be implemented, etc., etc., etc. I had one of my colleagues saying we're not convinced about the evidence, and show us the evidence, and that response. What appeared afterwards was that this professor also had some commercial interest in these private clinics that are offering the scans. So obviously there are also some potential conflicts of interest. And this is just recently in the summer holidays. Parents of kids with cystic fibrosis are saying once again the Danish Health Authority, the Danish government should introduce prenatal scans for cystic fibrosis so you can have an abortion induced. So that's just to say how there are certainly some drivers constantly in the public sphere. Marketing from drug companies, etc. Technology is a driver just like everywhere else. It's fairly regulated in this country and certainly less regulated in other countries, but there's always room for improvement. Technology, especially introduction of medical technology, is less regulated, also in this country. Politics, patient representatives, very strong drivers. I just gave you some examples. I think for politics, the driver is often the need to act. That's very much a emotional driver of elected politicians. Somebody's presenting a case. We are not doing well enough for cancer patients, diabetes patients, etc., etc. We need to act. We need an action plan. And that is often a very strong potential driver for overdiagnosis. Defensive medicine is on the rise in this country for various specific reasons. So certainly both junior and senior doctors are getting more afraid of malpractice. It's not so much about money driving malpractice suits in these countries, but it's certainly a driver. Medicalization, I think we see in several ways. I'll just mention one that I'm a little bit concerned about, and that's the driver for medicalization that is stemming outside of the healthcare system. For instance, social care in this country. We have a generous welfare state to receive benefits from the local communities, social care, etc. There's increasingly a drive towards diagnosis. You need to be seen by a doctor to get non-pharmacological treatments offered. That is very concerning. And then professional vanity is my label for usually doctors, often of the male gender, across specialties. I'm not saying this pediatrician is driven by professional vanity, but it certainly could be a person like him who is very keen on showing that I'm a good clinician, I'm a good researcher, I'm known, patients come to me, I can do stuff. That is a very, very strong driver of overdiagnosis, I think. Productivity, by that I mean the need in our healthcare system is fairly effective. We have rapid turnaround time in hospitals. So for instance, if a patient arrives at the emergency room in a hospital in this country, there's an urge to do a rapid turnaround. So complete blood analysis, CT scans, ultrasound of the abdomen will be ordered with a lower threshold than compared to 10 years ago. Not only because of defensive medicine, which which is certainly a driver, but also driven by productivity, because you need to have a quick turnaround so you can get the patient out of the emergency room, back in the home or up in the ward. And complexity. We have an extremely centralized and specialized hospital system in this country. And we have, in the Danish Health Authority, also during my directorship, been drivers of that specialization. And we have harvested immense improvements in quality by that, but that is certainly also driving overdiagnosis. So there's always a balance of benefit and harm that we are aware of. Here we go. So what I'm going to do now is I'm just going to give you a few examples of where I would argue that we have, from the Danish Health Authority, tried to counter overdiagnosis. I'm not avoiding the blame that we can also be drivers of overdiagnosis, or we can be the pawns of politicians, etc., in driving overdiagnosis, but we are also aware of that, and we are trying to counter it. And I'm going to give you a couple of selected examples, and these are certainly not made by a systematic review or anything. This is our house. We have approximately 200 staff here in the center of Copenhagen. We've existed for more than 100 years, and I sort of talked already a little bit about our tasks as a government agency, just to say that we are not directly providing care. So it's not like the NHS. We are not funding care, providing care. Somebody else is doing that. We're sort of sitting on top of them, trying to regulate. One of the things that we have done, and very close to my heart, because it was one of the projects that I introduced when I started in 2011, is working systematically with evidence-based medicine when we define best practice. When we define evidence-based guidelines, we need to work very systematically in the way we treat, assess, and synthesize evidence. That was not the case before. We introduced and implemented GRADE, and we adapted the agreed standard. We were not the first in Denmark to introduce that, but we're certainly the first to do it on such a large scale. We translated and versioned it into Danish, and we have very much, with that, set the standard for how to deal with evidence-based medicine in this country. We're also using several other recognized and validated instruments for assessing various types of evidence. In the last couple of years, we have developed and published all our evidence-based guidelines in the MAGIC app, which is spearheaded by our Norwegian colleagues, but we've also participated in that development, and you're welcome to visit that website, and you can find all our evidence-based guidelines, and I think there will be some of them in English, full version, and a lot of them will have, most of them will have summaries in English. We are also, with a new project, funding and supporting the development of guidelines in professional societies, but they have to stick to our standards. We have also, as part of this utilized criteria for selecting topics for developing evidence-based guidelines. And this can certainly also be areas where we see variance, burden of disease, controversy, or even overdiagnosis. And we have tried, and I think also succeeded, perhaps not perfectly, in balancing recommendations both for and against interventions. Certainly, guidelines and evidence-based guidelines, even well-produced evidence-based guidelines, can in themselves be drivers of overdiagnosis if they're not balanced in their recommendations. And I'm going to show you a number of selected recommendations that I picked from our evidence-based guidelines. I admit this is cherry picking. I admit it's not a systematic review, but I did, for this presentation, review all of our published guidelines since we started in 2012. And I was once again positively surprised about the number of recommendations we have recommending against something. These are just some selected recommendations which are certainly aimed at diminishing and limiting overdiagnosis. Take the example of dystocia in premenopausal women. This is a very sort of clinical and subjective diagnosis that often drives interventions such as drugs to reduce contractions, even surgical delivery or cesarean section. What we said and found evidence in favor of is that this should not be allowed for the single clinician. This is usually a midwife. So the midwife needs to consult with the senior midwife senior midwife perhaps needs to consult with a doctor before you enter the diagnosis of dystocia, and then perhaps induce with interventions. We also advised against screening risk group for depressive symptoms with borderline personality disorder, and as a very, very clear example of a very specific recommendation not to do something because you don't want to look for a diagnosis that you're sure to find, and this is, you must not, as a gynecologist, ultrasound scan the ovaries of young women with bleeding disorders, because you will always arrive at an ultrasound diagnosis of polycystic ovaries. So, and that was I think, a very, very clear example. So that is certainly not best practice to do that, and you will certainly overdiagnose and overtreat that young woman, also considering how frequent bleeding disorders are. Recommending against ultrasound and MRI in suspected meniscal lesion, certainly in other countries, other economies than our other healthcare systems, a very, very big driver. We do not have the economic incentives that are very strong for driving that, so that's more the professional vanity or defensive medicine. We also recommended against routine MRI scans in recent onset lumbar nerve root compression, so again sort of shifting the focus in favor of non-pharmacological, non-surgical treatment, but also non-diagnostic wait and see before doing scans. Osteoarthritis of the knee was one of the very first evidence-based clinical guidelines we developed, and I had the pleasure of chairing that committee consisting of orthopedic surgeons, physiotherapists, rheumatologists, etc. There was a lot of arguing, a lot of haggling, and one of the major discussions we had in that group between orthopedic surgeons, radiologists on one side, GPs, rheumatologists, etc. on the other side is, do you need an X-ray to make the diagnosis of osteoarthritis in the knee, or can you make the diagnosis in general practice purely on clinical symptoms? With the orthopedic surgeons would say, we need an X-ray, and we ask them, why do you need an X-ray? We need an X-ray so we can see if we need to do surgery. And we were sort of saying there's increasing evidence that physical exercise, etc., can actually diminish symptoms, prevent surgery. So we arrived at and made the recommendations that you do not need an X-ray. It's not forbidden to do an X-ray, but you need a better indication than just arriving at the diagnosis. So these are some of the examples of what I would say clear recommendations aimed at diminishing overdiagnosis. And these are sort of a couple of selected recommendations that are more sort of focused on diminishing overuse or over treatment. And I'm not going to go through them very much. You can see them here. And obviously, you know, a lot of these cases, tonsillectomies, tympanostomies, etc. I think we have a very, very large degree of tympanostomies in this country. And this can, along with cataract surgery, which is another example of what we try to look at, there will be economical drivers, because this is not done in hospitals and public hospitals. This is done in private practice for taxpayer reimbursed. So there will certainly be a driver for financial incentive to put in tubes in the ears of kids or do cataract surgery. Okay, so these were evidence-based guidelines, and finally I'm going to give the example of radical prostatectomy, which is an area where we have tried with different interventions from the Danish Health Authority over the last couple of years, aiming against overdiagnosis and overtreatment. And we have failed, not completely, but we have not been successful either. We have for many, many years and repeatedly recommended against screening for prostate cancer. We do not have a national screening program. We are not recommending opportunistic screening for prostate cancer. We have, a couple of years ago, locally, GPs, etc., developed decision-making instruments for GPs and patients on when not to do a PSA, or why not to do a PSA, and why you need symptoms, etc. They have been somewhat successful, but there are still some local variations. Then we tried a couple of years ago, because we have these very rapid patient pathways for cancer patients, which is very effective in arriving at diagnosis and treatment. And the cancer patients are very happy about that, and we have certainly improved survival of cancer very much by that. But there's a flip side of everything going too fast that also drives overdiagnosis and overtreatment. So what we tried to do in this pathway was to induce a filter function, saying that you cannot go ahead with treatment, especially surgery, without having the patient seen, you can say a second opinion, by a specialist to be sure that the indication is the way it is. That's limited somewhat, but still not enough. And you can see over here, which are the rate of men with prostate cancer in these 5 regions of the countries, how many are offered a radical prostatectomy. So you see one thing, increasing utilization of radical prostatectomy, also a large regional variation which cannot explain by demographics. Survival after prostate cancer have not improved similarly. So what we have done recently, and this guideline, which is a very strong guideline, will be published very, very soon, within the next couple of months. It's in public review now, is saying that we need to tackle radical prostatectomy. So we have in this guideline formulated risk assessment for men, low risk, life expectancy, etc. And we are saying very, very clearly from the Danish Health Authority, active surveillance is the first choice, not surgery, for this cancer. So active surveillance is a systematic follow-up of the man with prostate cancer, not offering surgery. Not in the same, you can do curative therapy at a later stage, but not offering surgery. And you can see there's a large variation between the 6 departments we have limited this procedure to, and we are using these numbers prospectively to see if they will comply with these guidelines. And we have also asked them to code active surveillance. They are now coding surgery, but they are not coding active surveillance. So we are basically taking a non-surgical treatment of a diagnosed cancer disease. We're taking a non-surgical treatment for a certain patient group, putting it on an equal or even superior footing as opposed to the surgical therapy. And we are saying that they should monitor it, and we will follow up, and we will see how they perform. And I'm very,
2 minutes on.
yeah, I know, I think I have only a couple of slides, and I think this is an interesting case to follow to see if it will be somewhat more successful. We should have done this years ago, but never late than never. Okay, I don't have much time to talk about the screening programs, and I'm certainly not going to argue I don't have time to argue why we have the screening programs we have. I will just say one thing. We are trying to be fairly transparent as regards to the processes and criteria for considering screening programs and developing screening programs. And this is accessible in this guideline. Unfortunately, most of it is in Danish. We do have 10 recommendations of when we need to consider national screening programs, and the last criteria is that we also have procedures in place for when to stop a screening program. We try to balance our patient information using absolute risks, and that was certainly a thing where we didn't do it earlier. So finally, I'll just say some of the challenges that I see is very much concerned about is the drivers of technology. The rapidity of implementation of new technology is so rapid. Take personalized medicine, genomic medicine, etc., but also the introduction of surgical robots, that we do not have the time to this elaborate consideration of evidence, etc., etc. And there's also an imbalance in research. So this very expensive technology will be employed for these patients, but sort of tackling public health measures in combating obesity will not. So there's certainly an imbalance that I would like to see sort of rebalanced. Thank you very much, and I'm sorry if I overstepped the time.